Thank you, Dr. Bennett and Dr. Priya and Anju for giving me an opportunity. As you all know, tuberculosis, if we who are there for a few years, we knowing that over time, we are seeing less and less number of tuberculosis cases in our state. So we are actually fortunate that we are not seeing much of this dreaded disease. But there is a real challenge faced by us. That means it really tests the skill of a clinician to identify a case of tuberculosis in our population, especially children. So I'll be just highlighting the epidemiology of childhood tuberculosis. So this is the zero deaths by tuberculosis. That is the slogan, or that is a catchy slogan which has been entrusted for all the healthcare providers regarding tuberculosis. So how is this possible? What is the burden of tuberculosis world over? We all know when we think of tuberculosis, we think it in confluence with HIV, another dreaded chronic disease. So when you think of sub-Saharan Africa, you see tuberculosis and HIV as a real burden there. So in India, when you think not adult, not childhood, when you consider India, it actually we take responsibility for, we must take responsibility of around 1/3 of the global TB population. And of this childhood population, as I said earlier, it is decreasing over time. So the last report, the global TB report says only 3.42 lakh children. And the pulmonary form of tuberculosis is still more common in children, but when compared with adult, the extrapulmonary forms of tuberculosis form a large proportion. As you all know, the serious forms of tuberculosis in children belong to this extrapulmonary group. And RNTCP, as you all know, well aware, is actually doing a great job. And earlier when we were studying, we used to see 10% of cases for childhood tuberculosis, but recently it is 6% of the cases referred to RNTCP in children are less than 14 years. So that is also a good thing for us. And tuberculosis deaths, however, are underreported in children. So this is the word, that is, there is a large detection gap. So this is what the national forums were all telling us. That is, overall in India, there is 56%, and it is a huge 70% under 5 years. So what do you mean by this large detection gap? We all know tuberculosis presents with the common symptoms for any other childhood illnesses like fever, cough, or weight loss. So these are all in a country with a large number of children with malnutrition. See, this weight loss or not gaining weight need not assume much significance. So to identify, as I said, to identify the children under 5 years who have got clinical infection and to prevent them from getting the disease, it's very, very important. So unlike the other illnesses like COVID and all, we know you get the disease, you usually become symptomatic, or even if you are asymptomatic, it's a mild disease. But tuberculosis is a disease which is so different in epidemiology. So we all know it's produced by the agent is mycobacterium, which affects the human beings. And it's very linked to the virulence of this microorganism and also to the host immunity. So that is the significance in children, especially infants. By meaning infants, it can be even less than 2 years children, or up to 5 years. Or children who have got other comorbidities like HIV, other immunocompromised children, children who are on chronic drugs like steroids or other immunosuppressant drugs, all these children are at a high risk. Or along with that, the environment also forms a very important thing. By telling of environment, we all know it, although not strictly underprivileged, some areas in India, that underprivileged status is very important. And they live in small households, hardly any rooms. Really, there'll be overcrowding. And that is very, very important. That means the environment in which these children live are also important. The most important one is all people who get the bacteria, they need not produce symptoms. That means they need not show symptoms of disease. in tuberculosis, the most significant thing regarding the burden is the latency. That means there is a huge population of adults who will have this disease latent, and they can result in a reactivation of latent infection later when they themselves become immunosuppressed. For example, in our place, diabetes is a important condition which produces immunosuppression. So this latent, huge adult latent pool of the adults is one population. So that is one important thing. That means to identify these latent, whether we can identify this sort of latent uh, infection in children, and whether this can be tapped so that you can prevent a huge adult pool of those with latent infection. So this is actually one area which is actually in the highlight. And for people in our place, the risk of progression to disease is 5 to 10% over lifetime. It will be more for a smaller infant. And that means in infants, it will be around 50%, whereas over 1 year, it may be around 25%. In our place, severe malnutrition, that is a very important condition which results in an increased burden of tuberculosis. Similarly, is HIV, but fortunately, HIV TB co-infection is less in our country. So when you think of the challenges of managing tuberculosis in children, tuberculosis, we all say, child is not a miniature adult. Similar thing is applicable to tuberculosis in children is not a miniature replica of an adult form. And then the most important one is the tuberculosis control activities in our country are always, or were and always, they were looking at the adult population. Why? Because the adult population is the population who have got a large number of bacilli in their lungs, and they can spread the disease, whereas children are paucibacillary. And apart from a few children in adolescence, children usually do not spread the disease. So the tuberculosis control activity, which was historically very much adult oriented, has to change to include the pediatric population also. And as I said, the dissimilarities in the pathology in tuberculosis, that is also very important, because TBM, tuberculous meningitis, and disseminated tuberculosis being the most severe forms. So doctors who have seen this TBM child will know how the child is doing after getting the disease. Even if you start treatment, everything well, the quality of life usually is very poor, especially if it's a symptomatic TBM. So these are the real challenges for managing tuberculosis in children when you consider the pediatricians. That is, they are paucibacillary. So how to identify? There is no easy point of care diagnosis. That is a core thing. And usually these children get from an infected adult. So contact tracing is also very important. And if there are other adults also, they can again get exposed to an infected adult in their lifetime. And getting the sputum in a pulmonary form, that is very, very difficult. Although we say we have more than 5 years, we can try for induced sputum and all, but now gastric aspirate has come as to get an easy specimen. But still we know in our state, we do not have much yield from the gastric lavage. So how to improve the quality of the gastric lavage is all very important. And regarding another investigation which we commonly use, that is the chest X-ray. There is a huge inter and an intra-observer variability is there. And fortunately for us now, chest X-ray is mostly available in most places, but still that variability in the reader variability is there. And more extrapulmonary tuberculosis are there. So that is also a challenge for managing. That means the pediatricians have to be very sensitive, or we have to be very careful when you manage. We see common symptoms like lymph node, weight loss and all. So shifts in strategy have to be planned, and that is what has come with the revised program. That means rapid molecular testing has been adopted, and universal testing for rifampicin resistance has been included. Currently, it is a gene expert, which takes around 131 bacilli per ml. It will be changing to an ultra. That method will detect even smaller number of bacilli, and to decrease the time for getting the culture, liquid cultures are also available. So when you consider the pyramid of TB diagnostics, the most important, what we usually see is the symptoms that will be dealt with the clinical next speaker. The tests which we do are the tuberculin sensitive, the test and the X-ray, that is the conventional radiology, and the molecular confirmation by universal drug testing. So the old pyramid of TB diagnostic has changed to the new diagnostic, which includes molecular testing. So that is actually a paradigm shift which has occurred to control tuberculosis in children. And regarding the services, lots of improvement has occurred. The CBNAT has come. There is a molecular diagnostic testing initiative for promoting affordable quality tests for TB. Quality drugs has been made available. Incentive for private practitioners, direct bank transfer to these TB patients, and an app-based management for tuberculosis. They all have actually going to improve the tuberculosis management in our country. I think I've ended it. I think that's end.
Anju?
Madam, thank you for the wonderful presentation. Now, we will have the question answer session in the end of the whole CME. Now, we'll move on to the second topic. It's Pediatric TB Clinical Features by Dr. Anju Kanmani, Consultant in Pediatrics, CHC Vithura. Dr. Anju?
Yes, madam. Shall I start?
Yeah, please. Please. Share your screen.
Yes, ma'am. Shall I make it full screen, madam? Madam, am I audible, madam?
Yeah, you are audible. Please make it full screen.
Yes, ma'am.
You may start.
Let it come, madam, actually. It's taking a little time.
Requesting all others to kindly mute your microphones other than the speaker.
Madam, am I audible? Is the screen visible, madam?
Yes, yes.
So thank you, Anju madam, and thanks, Geetha madam, and respected seniors, friends and colleagues. So I will directly go to the presentation. It is based on childhood TB guidelines updated on 2020. It's a national TB elimination program with the association with Indian Academy of Pediatrics. And we know about, when we talk about the clinical features of tuberculosis, we usually think about fever, weight loss, myalgia, night sweats, evening rise of temperatures, and things like that. This evening rise of temperature, it's actually associated with the TNF alpha and the evening decrease in the serum level of cortisol and all. But as far as NTEP is concerned, when we think about the common symptoms of tuberculosis, these are the symptoms that we should be aware. We should seek from the patient. That is fever for 2 weeks or more, unremitting cough for 2 weeks or more, no weight gain despite adequate nutrition, or loss of 5%, more than 5% of weight in the past 3 months. Then for extrapulmonary TB, this peripheral painless swellings or lymph nodes, then meningitis of in-series onset, the clinical features like fever, headache, seizures like that, then spinous deformities like gibbous, and any non-specific symptoms in a contact of an infectious TB case. Let us see one by one. Now, these are the basic things like it is an acid fast non-spore forming non-motile pleomorphic gram-positive one with the obligate anaerobe acid fastness is there. The incubation period can range from months to years, and it transmits as an airborne mucus droplet nuclei. Now, as Geetha Madam was telling, there are three things that we should be knowing about. That is, one is there is a concept called exposure, where the child has got significant contact with an adult or adolescent with infectious tuberculosis, or a tuberculosis infection where the Mycobacterium TB survives intracellularly within the lung, and thirdly, with the signs and symptoms which is over the disease. And now these four terms also we usually hear. There is primary tuberculosis and the progressive primary tuberculosis and the latent tuberculosis where the patient has a TST positivity, this Mando positivity, but the progression of the disease is not acting there, and the late reactivation of the disease. Well, in 2019 guidelines, we heard that this division is actually arbitrary and it is actually a continuum. We cannot set them into compartments like that. And this is a famous Walgren's timetable of tuberculosis disease. And we shall pause a little here. If you take the first year of tuberculosis infection, which is in months, first the immune conversion as well as the primary complex formation occurs. Then the local lung complication like fibrosis, calcification, all those things happen. This is followed by pleural effusion. Pleural effusion can be concomitant with the primary infection or it can occur later. Then there is a miliary or meningeal involvement, which is very important. It occurs with the primary infection within the first year. And if you consider the bone skin secondary breakdown, which is the reactivation and the renal involvement, that may take years or even decades. This graph tells us that the safe period for any child is the school age, because during infancy, the tuberculosis, meningitis, and all those things can happen, and the symptoms can actually come down and going into for a late bimodal presentation, the late peaking and the adolescent period, which will present with an adult type of tuberculosis. Now, we will see the case of Samir, who is 5-year-old and has fever and cough for 3 weeks duration, has taken oral salbutamol for a few days, has not been growing well. Mother is under treatment for TB. Now, the mother asks, is my child having TB? Now, what are we expected to ask in this child? Fever and cough, oral salbutamol, not growing well, mother is under TB. We should ask about the details of the symptoms. First, cough. What is the duration of the cough and the pattern? Like how long the cough has been there? Was it for days or even weeks or months? When was the cough more? Because the most common cause for cough, the reactive airway disease, whether it was more during night or in the morning, or was it paroxysmal or was a barking type of cough, things like that, and the pattern of cough. Fever. It is very important to have a documented fever. So we can ask the mother to purchase a thermometer and document the fever so that we can really think whether it's a fever or not. And previous weight record. So in order to know this, whether the child is not growing well or not, whether the child is growing well or not, we should have a weight record. This we can get from the immunization record. Then mother is under the treatment of tuberculosis. So we will have to ask about the mother's disease also. What type of TB it is? Is it a pulmonary TB, an extrapulmonary TB? Is she on treatment? Is it an MDR TB? And also we should think about who else is there in the family. Now we have got the answers. The cough is persistent. Fever is documented, 100 to 100.5. Unfortunately, there is no previous health record, weight record. And mother is a pulmonary tuberculosis, but the sputum status is not known. And she is on anti-tuberculosis treatment for 2 months. He has 2 siblings, 9 months and 12 years. Right. Now, a few words about the cough. Chronic cough is reported, and we should define the cough. And for that, the NTEP is giving citing a study here, which is a prospective study done in Cape Town with 151 subjects, 0 to 13 years, who had cough of 2 weeks or more. 15% had persistent cough, and tuberculosis was diagnosed in 10%. Now let us see this graph. The first graph, this first charting shows that tracing shows the intensity of cough has increased initially during the first week, and it has gradually decreased. That is acute with a delayed recovery. This usually occurs in an infection, usually viral infections. Now the second tracing, if you see, that is the first intensity of the cough is increasing first, then it is coming down, and after 1 week it is again increasing. This is a recurrent type of cough, usually occurs in reactive airway disease. Now just look at the third tracing, which is constant, it is being there, it is persistent, it is non-remittent, and it is actually increasing also. This could be tuberculosis. And if you look at this picture, there are 4 groups of blocks. The first one indicates viral infection, and the ash colored thing is an acute thing. So in viral cough, it will be actually an acute type of cough, which is more. And of course, sometimes it can cause recurrent cough also. In asthma, definitely the acute cough is not there. It is very little, but the recurrent type of cough is the most important. And tuberculosis, definitely it is the persistent cough, which is important, and other groups. So finish with the cough, we'll just go to the not growing well part. That is a relatively soft sign, common with the poor feeding habits. Malnutrition, undernutrition is very rampant here. It could be due to heavy worm infestation or food insecurity. And it could just be a perception and not real. Mother will be feeling and comparing the child with other children and telling that the child is not growing well. So, and also you should always keep in the phalanxes regarding the checking of the weight, like whether it is the same weighing machine which is used, the zero error which is corrected or not, machine errors, etc. And of course, the object, the issue of weighing with the clothes also. So, being taken into care of those three symptoms, we will just group and define these three ones. There is a persistent unexplained fever, persistent cough, and definitive weight loss. By definition, a persistent cough should be there for more than 2 weeks duration, and it should be unexplained more than 38 degrees Celsius. It should be reported by a guardian and objectively recorded at least once. A persistent cough should be there for more than 2 weeks. It should be a non-traumatic. And definitive weight loss, by definition, should be more than 5% loss in the past 3 months, or failure to gain weight in the past 3 months, despite adequate nutrition with no other apparent cause. So, we have seen the case of Samir, and we know these common symptoms of tuberculosis. Now, we have come to the conclusion that the most important things that we should look about is these 3 symptoms of persistent fever, persistent cough, and definitive weight loss. Now, mother is pulmonary TB positive. Pulmonary TB is there. Sputum status is not known, and ATT has been taken for 2 months. What is its significance? Here comes the definition of contact, importance of a contact. By definition, exposure to an infectious TB patient, lung or airway involvement due to TB in the past 2 years. Now, let us consider this in detail. If the child is asymptomatic, we are not assessing him for tuberculosis. So if he's asymptomatic, we need not take care of the contact symptom. Now, if he is symptomatic, that is, if he's having fever, cough, chronic cough, persistent cough, and things like that, then we should think about whether the child is having a contact or not. In this case, the point to be noted is that if the contact is either pulmonary positive patient or an extrapulmonary patient, it should be taken as a contact. That is, an infectious TB patient, lung or airway involvement due to TB in the past 2 years. Now, the question is why extrapulmonary also? That is given in the green letters. That is, in a symptomatic child, contact with a person with any form of active tuberculosis within the last 2 years may be significant, since there might be an unrecognized pulmonary involvement in the extrapulmonary patient. So, we have defined that it should be for the past 2 years, and if the child is symptomatic, the positive, whether pulmonary or extrapulmonary, that should be taken as a contact. Children and other household contacts of pulmonary cases of tuberculosis are at high risk of getting infected and developing disease. And that we will see in the next slide. Recently infected cases. How recently? For the past 2 years. So that finishes the contact thing also. Now, the child has 2 siblings, 12 years and 9 months old. Now, let us see what is the risk of infection with these siblings at all. This, I think, madam has already covered. When there is a source case, there is an exposure to contacts. 70% will not develop any infection at all, and they will not develop any disease. But 30% of them will develop an infection. And out of this 30%, according to the microbacterial virulence and the host immunity, they will either go in for persistent latent infection or they will develop a primary disease. Now, talking about primary disease, what is the risk of developing disease? That is, madam, I have already told, that is in 5 to 10% in the lifetime, and if it is less than 5 years, it is 25%, and in infancy, it is more than 50%. Now, we know that 30% risk of infection is there for the close contacts. The risk of progression to disease for that 9-month-old, it could be more than 50%, and the 12-year-old, it should be 5 to 10%. Now, but the smear status of the mother is not known. Does that really matter? What if she has a smear negative pulmonary TB? Now, let us see these 2 chunks, 2 blocks actually. The right side blocks is infected contacts less than 15 years, and the left side consists of 2 parts. That is, both are culture positive, but a smear positive group and a smear negative group. Now, in the right side, it is infected contacts less than 15 years, but we can find that most of the infected less than 15 years has got their infection from culture positive and smear positive pulmonary cases. And a small fraction of infected contacts has only got the infection from the smear negative cases. But the take-home message is that Smear negative and smear positive, culture positive cases can infect contacts less than 15 years. But the percentage is more in the case of smear positive. And this is a common question that we usually come across, that is when the patient can go in for work and how it becomes non-infective. Once treatment is started, after two weeks, there is ample clinical evidence to show that once treatment is effective, chemotherapy is the infectiousness of the patient becomes minimal. Well, one important thing is that if the patient is having an MDR TB, then the period of infectivity will be more. Back to Samir. So he was a TB suspect and he has now become a presumptive TB case. Persistent fever, unremitting cough, weight loss of 5% without contact with the patient, pulmonary TB in the past 2 years. I would like to tell that I was wondering in how much of these 4 should be there to label as a, for like a criteria like that. But in 2019, it is still in the or and like that only. But there are other opinion of certain people that at least 2 of them should be there to really suspect tuberculosis. Now, before finishing off, a few words of X-ray also. Whenever you take an X-ray, we should think about the right-hand lower side. We have got an acronym called PRIM, because as far as NTEP is concerned, the most important test that we do, the next step that we take once you suspect a case of tuberculosis is doing an X-ray test, not a Mando test. So while taking X-ray, we should think about something. What are those? One, the penetration should be correct. The rotation should not be there. Ideally, it should be positioned. It should be an inspiratory film to ideally comment on, especially hilar lymph nodes. It will be, we can confound, it can be confounded. And the child will be properly restricted also. Now, there are certain findings in X-rays which tells us that this could be tuberculosis. They are primary complex, consolidation with or without cavitation, atelectasis, emphysema, pleural effusion, and miliary pattern. Now, if you take a chest X-ray in a suspect TB, there will be only 2 results. One, it would be abnormal or it could be normal. If it is abnormal, it could be 2 types. That is abnormal and TB suggestive, and abnormal but not TB specific. These are typical X-ray findings seen classically described in tuberculosis. The first one is a lymph node X-ray with parahilar, paratracheal involvement is there. It is very large also, and that is one important finding there that we will discuss later. And this second one is that of a miliary tuberculosis. Miliary tuberculosis speckled finding will be there. Speckled, lung zones are seen. And the extreme right, you can see hypertranslucency in the right lower lobe. That will be probably a fibrocapture lesion. These are all suggestive of TB. Now we should be careful about the confounders. But summation shadows are shadow in shadow appearance, multiple opaque shadows seen. That could be mistaken as a consolidation. Then overlays like hair braids, lock of hair, etc. That can be mistaken as a consolidation. Then of course in the infants and small children, the thigh muscles. Lymphadenopathy has got direct signs in chest X-ray. It could be either sharply demarcated and lobulated density or ill-defined vague borders, or it could be indirect signs like the trachea contour will be different, or the tracheobronchial tree will be altered. There will be spraying of carina also. Now, this is an important slide because it shows 3 features common to primary infection. Patient may have non-specific mild symptoms which can go unrecognized, or a primary lung foci are usually quite small related to large hilar nodes. This is important because if you see that X-ray, you can find that the hilar adenopathy is larger than the parenchymal involvement. That is very typical of a primary complex. Then primary foci may resemble pneumonia and may be located within any lobe. A word about the pathophysiology and all, 2 or 3 slides only are there. The primary complex indicates the local infection at the portal of entry with the regional lymph nodes that drain the area. It usually occurs in the areas of greatest ventilation, like middle lobe, the superior segments of the lower lobes, the anterior segments of the upper lobes. The relatively large size, this we have already discussed. Then bacilli will multiply in the alveoli type 2 pneumocytes and non-activated macrophages. These lymphocytes will recognize these antigens and they proliferate. That is where this lymphocytosis occurs. They secrete lymphokines which attract lymphocytes and macrophages with high concentration of lytic enzymes. And this we should be knowing because interferon gamma and TNF alpha, these 2 things are very important in the pathophysiology of tuberculosis. But what does the mycobacterium do? It has got sulfatide in the cell wall, which inhibits the macrophage phagosomes and lysosomes, which is important in destruction. And since it can be inhibited by the sulfatide, it will escape the destruction of intracellular enzymes. Now, most bacilli are killed by some, but some may survive within non-activated macrophages, which carry them to lymphatics, to regional lymph nodes and body tissues, brain, kidneys, bones, etc. Now, when the antigen load is small and the tissue sensitivity is high, granuloma formation occurs. But clinically, at that time, there will be inapparent metastatic foci in many organs, maybe origin of the extrapulmonary and reactivation tuberculosis. Now, when antigen load is high and the tissue sensitivity is low, reaction is diffuse and not well contained, that will lead on to disseminated tuberculosis. And let us look at a few images. This is a very easy one. We have got this paratracheal lymph nodes with the, both the right paratracheal and the right halar lymph node. This is a primary tuberculosis. With the lymph node disease, there is no airway compression. This is also very important. In primary tuberculosis, there will not be usually airway compression, and there will not be any obstruction or collapse. This is also very easy. Right lower lobe zone hyphasis is there with the lymph node. The second X-ray also, if the parenchymal involvement is more. This is the primary complex. Now, what happens in the primary complex? The tissue hypersensitivity and the cell-mediated immunity develops in 2 to 12 weeks. The parenchyma heals completely by fibrosis or calcification after undergoing caseous necrosis. And delayed hypersensitivity, this is important. The further halar involvement occurs, it causes obstruction. And when it causes obstruction of the bronchus, this area distal to the obstruction will go in for hyperinflation. That will result in atelectasis and collapse consolidation. Now, if that caseous node was inflamed, what will happen? That will attach to the endobronchial wall and will erode into the bronchus. That will result in endobronchial tuberculosis or a fistula tract. And while eroding, the caseum can cause complete obstruction, and that can also result in a collapse. And the subcarinal node enlargement, that can result in esophageal compression and bronchopleural fistula. So we will finish the presentation with the 3 things, that is progressive pulmonary and reactivation. That are the 2 topics are left today. So in progressive pulmonary disease, primary focus enlarges steadily and develops intense caseation. Center of the lesion liquefies and empties into the associated bronchus, leaving a residual cavity, which will contain a large number of tubercle bacilli, which is important treatment and further, the natural cause of disease. The sloughing of the necrotic material into adjacent bronchus will cause intrapulmonary dissemination. So high fever, severe cough with sputum protection, weight loss, night sweats. There will be diminished breath sounds, rales, dullness or egophonia over the cavity with the treatment, but the prognosis is good. Now, this will, so this is an interesting X-ray. We can see that the tracheal shadow is coming like that. And here on the right side, we can see that the right bronchus is actually narrowed and the left one is a bit, bigger and lumen. It shows that there is something which is compressing here, probably this hilar lymph node. Now, a bronchoscopy when done, what happens is that the right main bronchus can be seen here, which is narrowed, and the left is having a bigger lumen. So this is probably a compression. This is a progressive primary TB. Different from the primary TB, here there is obstruction. Lymph node disease with airway compression, hyperinflation right lobe, no collapse. This is also another it's a progressive pulmonary TB. This is a parenchymal cavitation with the consolidation which is happening here. And the right side here also you can see there's a cavity inside this and a consolidation which is happening there. Now, reactivation or post-primary tuberculosis. Sorry. Reactivation or post-primary tuberculosis. Now, we have already seen that there are multiple causes for a normal tuberculosis when mycobacteria, when it gets inside the patient. Now, this one is a reactivation, which is a post-primary tuberculosis. The importance we have already, most of the findings we have already discussed because adolescent adulthood, because it occurs later. If the infection occurs 1 year after the primary infection, symptoms occur 1 year after the primary infection, that should be actually a reactivation. And it will be rare if the primary infection has occurred at an age less than 2 years, but it can occur if it was more than 7 years. And there is a predilection for apical or posterior segment of the upper lobes. This is called Simon's focus, or the superior segment of the lower lobes. And focal or patchy heterogeneous consolidation of the cavitation, and pleural effusion. Fever, malaise, anorexia, weight loss, night sweats, fatigue of hemoptysis, and chest pain will be there. The importance is this is highly contagious. This is important when a child resides in the home. Even with large cavities and infiltrates, physical signs will be minimal. Here also the recovery is good, but the cough may last for months. This is a post-primary cavitary pneumonia, post-primary reactivation, fibrocavitary pneumonia in the right upper and the left lung. Just one mark it here. And lastly, about the disseminated disease. Here the bacilli are disseminated to distant sites like liver, spleen, skin, lungs, bone, kidneys, meninges, spleen, bone marrow, and other tissues. Lymphohematogenous spread is usually asymptomatic, but most often it will be indolent and prolonged. But spiking fever will be there relating to the release of the bacilli into the bloodstream. Or it could be an explosive with anorexia, fever, hepatosplenomegaly. Most commonly seen in infants and children. The pulmonary involvement in disseminated disease will be surprisingly mild. Miliary occurs when occurs 2 to 6 months of primary infection, and the lesions of tubercles will be less than 2 millimeter. Dyspnea, pneumothorax, hypoxia, headache, meningitis, choroid tubercles in 13 to 87%, and disease should be there in more than 2 organs if it should be miliary, disseminated one. And the TST is non-reactive. And this is a typical miliary TB picture. This is something else. It is a cavitary pneumonia. Sorry, that has again come. So this is the last slide, which tells us about the primary infection which occurs. If it is contained, it naturally heals, but could be treated also, and both can result in reactivation disease. But the point is, the risk is much higher with the natural healing as compared with those treated. That means if the disease is getting contained by natural healing, the possibility of reactivation is more. Then the bones focus is parenchymal cavitation, contiguous rupture, pleural effusion, the regional lymph nodes, what happens, airway involvement, partial complete obstruction, these things we have already discussed. Thank you.
Thank you, Dr. Anju, for the very lucid presentation. Now, before we move on to the next topic, we'll break for a short moment to release our second newsletter of the Trivandrum IAP. We have both the state office bearers with us. May I ask Dr. Narayanan to just say a few words to us before our State Secretary, Dr. Balachandra, will be releasing the newsletter. Narayanan sir, are you here?
Anju, I think Narayan sir has gone. Yes, for the meeting.
Okay. Okay, sir. Okay, now I request State Secretary, Dr. Balachandra, to kindly release our second newsletter of Trivandrum IAP. Over to you, Bala sir.
Okay. Can you stop the screen share, please? Anju, can you stop the screen share? Yeah.
Priya, could you please stop the screen share? Yeah.
Yeah, it's done. So, respected President Dr. Bennett sir, Secretary Dr. Priya, my respected teachers, IAP Trivandrum, today's faculty, Dr. Geetha, Dr. Anju, and Dr. Rekha, and all my friends. First of all, let me appreciate on the behalf of IAP Kerala State the efforts of IAP Trivandrum for their excellent community as well as chariot activities in spite of this pandemic. In addition to the academics, IAP Trivandrum has found time to release the first quarterly e-journal with excellent articles from our teachers and my colleagues in Trivandrum. And also they could release the Mambalam, the first arts album, that too in the same month in May. And last month, IAP Trivandrum released the first monthly newsletter, which is edited by Dr. Prashant and Dr. Amit, who has done the e-journal also. So I congratulate Dr. Prashant and Dr. Amit, and also Dr. Bennett and Dr. Priya for releasing all the 3 journals at a time, the e-journal, the arts album, as well as the monthly newsletter. Today I'm happy with these words. Today I'm happy to release the second monthly newsletter in succession, that is in July, the activities of June. So again, I congratulate IAP Trivandrum and all my teachers there who support the leaders of IAP Trivandrum in releasing journal. Thank you. Jai Hind, Jai IAP. Bennett sir will release the. Bennett sir will do the release, no? Anju?
Yes, sir. Yes.
Yes, sir. Bennett sir, you can share the screen. Bennett sir, any difficulty?
Bennett sir, should I share the screen?
Kindly do.
Amit, you can.
Amit, you
Please
can.
do, Amit.
Stop,
Yeah, Amit, please
stop
do.
sharing.
Please. I'll stop share. Okay. Amit, you can start sharing.
Okay, ma'am.
Thank you, Dr. Amit and Dr. Prashant for the wonderful work done. Now we continue with our sessions. We move on to the last session for today. We have Dr. Rekha Krishnan, Additional Professor of Pediatrics, SATH Hospital with us. She is going to talk on TB diagnostics and algorithm. Over to you, Dr. Rekha. Dr. Rekha, please unmute yourself.
Hello, Keka.
Keka.
Good evening, everybody. First of all, I would like to thank Dr. Priya and IAP for giving me this opportunity, and Balendran sir for giving the opportunity for me to attend the training program, tuberculosis program. And over to the topic. And already Geetha madam and Dr. Anju has covered many points that I am going to tell also. So I am going to have a better job. And Geetha madam has almost covered everything in a nutshell. And Anju has elaborated all these pathogenesis, clinical features and all. And I will be mainly dealing with the diagnosis of tuberculosis, and mainly it is pulmonary tuberculosis. And that too, drug-sensitive tuberculosis I will be dealing. And about drug-resistant tuberculosis and extrapulmonary tuberculosis and all will be covered next week by the other speakers. And yes, and my presentation is based on, as understood, it is based on the Childhood TB Updated Guidelines 2020. And over to the same case that Anju has said, summer. And we will be continuing with the same case. And from what Summer and what Dr. Anju has said, now it may be clear for you that the first step in the diagnosis is taking a thorough history and doing a thorough clinical examination and reaching the point of presumptive pediatric tuberculosis. And the points are all, I think almost it is covered. That is prolonged persistent fever more than 2 weeks, unremittent cough more than 2 weeks, and weight loss with or without contact. That everything is covered. And our first role is to come to that first step in the diagnosis of tuberculosis is understanding that there is a presumptive pulmonary tuberculosis case. And the next step is chest X-ray. That is compared to previous diagnostic guidelines, the change is now chest X-ray has come to the upfront. And as already Anju has said, we will be taking when we are identifying a patient as presumptive pediatric pulmonary tuberculosis, the next step is taking an X-ray and read the X-ray and see whether it is highly suggestive of tuberculosis or non-specific of tuberculosis, or whether it is a normal X-ray. And almost most of the time, telling is very easy, but it is very difficult for us to come to a understanding after reading the X-ray. And many a time we may have to take a second opinion. And because this is the important part in the diagnosis, don't hesitate to take a second opinion if it is needed. And if everything is clear, like if it is a miliary tuberculosis, or if the hilar node is there, if there is a fibrocavitary lesion is there, highly suggestive, then there is no problem. But most of the time there will be non-specific chest X-ray findings. When sometimes we may have to get a second opinion also. And the third situation is the scenario is a normal X-ray. You have to make sure which path you are. And already the suggestive tuberculosis cases, already Dr. Anju has covered all those things. So I am going to just skip that. And when there is a, just telling that when there is a hilar node, they're all same has to be covered. Hilar node can be paratracheal, mediastinal, or this lymph node disease can be paratracheal, mediastinal, and it may sometimes press the trachea and cause partial either collapse or emphysema, depending upon the degree of pressure effect on the trachea and all. When these X-rays are straightforward, it's clear for us, but most of the time, as I already said, it's a non-specific chest X-ray. So the next step for us is to give a course of antibiotic and repeat the X-ray. So the most important part is don't give unnecessary antibiotics that has anti-tuberculous action, which is sometimes we have a temptation to give ciprofloxacin solid when there is a non-resolving lesion. So we shouldn't do like that. And the antibiotic of choice is most of the time amoxicillin or moxiclav, and usually linezolid, quinolones like ciprofloxacin, etc. should we are tempted to give, but don't give because they have anti-tuberculous action. And if already an antibiotic trial has been tried, you no need to repeat that. You can take a repeat X-ray and see. Now, this is the algorithm which I want to discuss. You can see that there is a presumptive pulmonary tuberculosis case of summer, chest X-ray suggestive of TB. Here, the suggestive of TB. And what is the next step? The next step is you have to get a sample because it is a pulmonary tuberculosis. The sample that we are going to send, as everybody knows, it is sputum. And here comes the challenge for us. As already Geetha madam has said, the two main challenges are, one is the difficulty in getting sample for a small child. Of course, you can get sample easily for an older child and adolescent patient, but there will be difficulty in getting a sample for a small child. And so we have the options of getting a gastric aspirate or induced sputum. And then we have to subject that sample for nucleic acid amplification test or CBNAT that everybody knows. That is the NTEP approved rapid nucleic acid amplification test. And either it can be positive or negative. And if you get a positive CBNAT test, then there is no confusion. You can take it as a microbiologically confirmed tuberculosis. And the specialty of this test is that we can identify rifampicin resistance also. And if there is no rifampicin resistance, then you can straight away treat that child, that patient, with the first line anti-tuberculous drug. So there is no confusion on that. And the second possibility is, if you may get a rifampicin resistance case, then you have to go in the pathway of drug resistance to tuberculosis that we will be covering in the next session, next week. And the other possibility is you may get a negative result. Then what will you do? Then if the child is having highly suggestive symptom of tuberculosis, you have to thoroughly search. You have to take again a proper history examination, thoroughly search for any other sites like a peripheral node from where you can get a fine needle FNAC lymph node aspirate, or you can try for a better quality specimen and subject to a repeat CB-NAT. Or you can always get a second opinion from a higher center and try to get a repeat result. And if the repeat NAT is positive, then there is no confusion. It is a microbiologically confirmed tuberculosis. But if the NAT is negative, and then our job has increased, that we have to find out whether we are missing some other illnesses. We have to rule out all other similar conditions and look for any other conditions like an extrapulmonary tuberculosis. And if nothing you can find out, then you have to treat that case as a clinically diagnosed probable tuberculosis. And this is the second scenario where you get an X-ray chest with a non-specific shadow that already I have said. You have to same you can give a course of antibiotic, then it is the same algorithm is continued. Then the third scenario, if the child is having a normal X-ray, then you have to evaluate for extrapulmonary tuberculosis and refer to higher center if needed and to investigate for alternate causes. This is the basic natural diagnostic algorithm for pulmonary tuberculosis. And
Rekha,
hello.
can you make it full screen?
Oh, okay. This is the presenter view. You can't see that, no?
The full screen.
Okay.
Okay, thank you.
The right corner എനിക്ക് കാണാൻ പറ്റുന്നില്ല, അതുകൊണ്ടാണ് ഞാൻ അങ്ങനെ presenter view ഇട്ടത്.
മുകളിലോട്ട് മാറ്റുക അല്ലെങ്കിൽ തംബ്നെയിൽ അങ്ങ് മാറ്റിയാൽ മതി. അപ്പൊ റൈറ്റ് കോർണർ ആ തംബ്നെയിൽ ക്ലോസ് ചെയ്താൽ മതി.
Okay. Thank you. Then now what is the next step? This is our patient. Is the diagnosis confirmed? It is highly suggestive. Now we have come to the our patient, and we can see that the chest X-ray is highly suggestive of tuberculosis. But are you sure that this is tuberculosis? That is our next question. No, you have to confirm your diagnosis and complete your diagnosis. How will you confirm your diagnosis? Confirmation is by showing or growing the pathogen. That is microbiological diagnosis. This is the new according to the 2020 new latest guidelines. This is coming up front, microbiological diagnosis, and our diagnosis will be complete only by knowing about rifampicin resistance. That is the next change. So you once again telling you have to history, clinical examination, come to the point of presumptive primary pulmonary tuberculosis. Next step is take an X-ray. In 3 routes you have to go, and then next step is confirmation by growing the pathogen or showing the pathogen, and complete diagnosis is by knowing about rifampicin resistance. And What are our for bacteriological diagnosis? What are our options? These are our options. One is microbiological diagnosis, and second is the molecular diagnosis. Previously, still microbiological diagnosis we are using, that is smear for acid-fast bacilli and culture. These are our two options. And for molecular diagnosis, it is CBNAT or cartridge-based nucleic acid amplification test. These are our options. So where do we use smear for acid-fast detecting acid-fast bacilli? Are we still using that? That is the question. The advantage is that it is cheap and simple, but the disadvantage is that the sensitivity is very less, and it is positive in only 10 to 15% of children. Even in positive cases, smear culture positive cases, we get very low sensitivity for smear. And to counter that, they have even introduced LED microscope, but still the sensitivity is very less. And even though there is a high level agreement between observers, that is a problem with smear. But still we are using that when, that is, if there is a patient is, if the NTEP approved NAT is not available and chest X-ray is not available, then you can, well and good, you can use smear. And at that too, if the patient can expect a sputum, then you can very well use smear. But when we are using smear, you have to get two samples. If one is positive, then it is positive, but you are not getting positive, then you have to get two samples. It's a must for smear. And the problem, another problem is we cannot identify rifampicin resistance here. Now, the next point is the NTEP approved NAT for molecular diagnosis. That is the most important highlight of present day tuberculosis diagnosis. We are using CBNAT. Different types of molecular diagnostic tests are available. The one we are using now is Gene Expert MTB RIF. And the other one that is written just below that, the second one you can see there is an extra ultra. That is ultra, Gene Expert, it's ultra. And TrueNAT, these are all other options. And line probe assay and LAMP, these are all molecular diagnostic tests. But for drug sensitive tuberculosis, first line we are using CBNAT Gene Expert. That is available in our, in Trivandrum Medical College, it is available in our microbiology lab, in TB Center and all, it is available. And line probe assay we are using for drug resist, mainly basically for drug resistant tuberculosis. And LAMP also are approved, but there are certain problems regarding the identification of rifampicin resistance and all. So you should just understand about CBNAT, which is the one we are using. And it is a real-time PCR rapid technique. And the highlight is, the most important part is that we will get a result in 2 hours. And in these 2 hours, we can both diagnose tuberculosis and also you can identify rifampicin resistance conferring mutation. And what is the importance? Why should you understand that the patient is resistant to rifampicin or not? This is the change in present tuberculosis diagnostic algorithm. If we are not identifying rifampicin resistance, then previously we used to give first line treatment for all patients. Even if we are the child is rifampicin resistant, that child will be getting the same first line drug, and so this child will not be cured, and that child will be spreading this disease to many people, and the organism will also acquire more resistance if you are on giving this first line drug for these resistant cases. So that's very important for identifying rifampicin resistance. And the CBNAT can be done in both respiratory and non-respiratory specimens. Initially, we were doing for respiratory specimen. Later, WHO has approved for other non-respiratory specimens also, like CSF and lymph node. That is in 2013. The other one was in 2010. And so And why rifampicin is the priority, that also everybody should know, that resistance to rifampicin is easily detectable for a majority of cases with molecular tests. And so that is the importance. And most of the time when the rifampicin resistance is there, there can be associated INS resistance also. And these are just for your information. These are the other tests. The importance, the change is that when there is an ultra, there will be something more is there, no? So the ultra means you understand that ultra has low detection limit. Even 16 bacilli per ml sputum can be identified by this ultra test as compared to 131 per ml for expert NTEP. And so our challenge in pediatric tuberculosis is that it is a post-bacillary disease. So that some amount this can be addressed by using this expert ultra technique. And TrueNat is also approved by NTEP, but now we are using expert NTEP. Then what is the role of culture? This is the third option for us. Liquid culture, MGIT, Mycobacterium Growth Indicator tube is used, and it is available through NTEP lab network. The importance, the specialty is that this has got a short turnaround time of only around 2 to 8 weeks. But previously used solid culture. Previously only solid culture was available, that is LJ medium, and it takes 3 months for this growth. And under current universal drugs susceptibility test strategy, when it is used upfront, with specimens like induced sputum, gastric aspirate and valve, this culture can be used. That is, we are using that when the patient is having symptoms highly suggestive of tuberculosis, X-ray is highly suggestive of tuberculosis, but still if you are getting a molecular test as negative, and if we are repeating the test with a better quality specimen, but still it is negative, then we are forced to diagnose the patient as a clinically suggestive tuberculosis, and parallelly you have to send a drug susceptibility test for liquid culture also. It is also available in our hospital. In our microbiology lab it is available. In between some reagent issues only is there. Otherwise they are doing that for selected cases. And both solid culture is also available, but we are always preferring this liquid culture where we get faster result. So if a specimen is positive by any of these methods, the case is labeled as microbiologically confirmed tuberculosis. And whenever smear is used for diagnosis, at least 2 samples should be tested, while a single sample is sufficient for NTEP approved NAT. And this, if the specimen is negative by NTEP, this already I have said. And in case of rifampicin resistance is detected on NAT, in a new case without any risk factors, a reconfirmation is desirable. Means we are getting rifampicin resistance in a patient where we are not expecting resistance, then that is in a new case, then we have to do a repeat NAT for reconfirmation also. Now, the next point is when sputum is not brought up spontaneously, what is the option? We have 2 options. One is gastric lavage and the second is induced sputum. Gastric lavage we are all doing routinely in our hospitals, but the specialty that you should understand is that previously we used to do overnight fasting, but now it is said that it can be done in an ambulatory setting after 4 to 6 hours of fasting with some loss of yield, but still it can be done. And basically, as you all know, it's an invasive procedure and we need trained staff. And some practical points is that when you are taking gastric aspirate, ideally we have to take it overnight in the early morning, because if the child is awake, then peristalsis will occur and all these gastric, this swallowed sputum will go down to the intestine. So it is preferable to take early morning. And if we are not getting a sample in the supine position, then you have to change the child into the lateral position and do a lateral position, right lateral position, left lateral position. And if still you are not getting a sample, you have to push or pull the tube little bit. And if still you are not getting a sample, you have to inject about 5 ml, 10 ml normal saline and then repeat the same procedure in the supine and lateral position. Somehow you have to get a good sample. That is very important for diagnosis. And the second option is induced sputum. Here, fasting is not that needed, but it's 2 to 3 hours fasting is preferable. Here, you can do it as an ambulatory setting. The technique is 3% saline. We are giving nebulization with 3% saline to induce cough. But 3% saline is a bronchoconstrictor. So, before giving 3% saline, you have to give a bronchodilator in the nebulized form. You can give nebulized salbutamol or salbutamol MDI. MDI is better, but still you have to have a nebulizer for giving 3% normal saline. And if the child is cough is stimulated after 3% normal saline nebulization, then it is okay. We can collect that. And if the child is still not inducing sputum, then you should do a chest percussion gently. And if still you are not getting sputum, then you have to do gentle suction of the oropharynx and nasopharynx. And this can be easily learned by paramedics. The only disadvantage is that there is high risk of transmission to the provider as it provokes cough. So you have to have good infection control measures. You should do it in an open room. And the N95 mask should be weared also. So that is the problem. And in 2 slides regarding our conventional and newer techniques. The conventional method was to diagnose most cases clinically with support of X-ray, Mando, AFB smear culture. And definite diagnosis was not usually attempted due to the poor sensitivity of the smear, which is under 10%, as well as the solid culture, which is around 30%. And the turnaround time of the culture is also 12 weeks. So, and also it does not differentiate drug sensitive from drugs resistant forms. This is the problem. And the highlight of newer strategic shift, this Geetha madam has already highlighted. Now, the universal drug sensitivity testing is in the upfront. And universal refers to that all cases are tested for drugs sensitivity, and it is not all drugs. And currently, all cases of TB are tested for rifampicin resistance to appropriately align therapy. And the availability of the more sensitive and faster NAT and faster MGIT is the highlight. Now, coming to our patient sample, and we have done X-ray suggestive of tuberculosis. We have collected the sample. We have sent for RNDC approved NAT. And NAT, these things I have already said. The specificity of NAT is very high. And it is a foolproof technique. It is safe for lab personnel. It is a closed system and no risk for cross-contamination is there. And this point I would like to highlight. The best yield of NAT is when it is ordered based on a suggestive X-ray and not symptoms alone. And always we have a tendency when you get a patient to say, send a CV NAT. So that should not be the case, and you should first take X-ray, and if it is suggestive only, you have to send a CB NAT. Otherwise, the yield will be less. That is a change in the latest as per latest guidelines. And for our patient, he was a NAT negative, and that does not mean that he is not having tuberculosis, because the limitation is that even culture yield in children with tuberculosis is around 50%, half. And CB-NAT yield is as much or less than culture yield. And hence, even a negative NAT does not rule out tuberculosis. And you can remember, PGs can remember these percentages. CB-NAT for sputum and gastric aspirate, the percentage detection positivity in culture positive cases is around 90% and 68%. Whereas for smear, it is 30 and 25 respectively. So the negative NAT does not rule out tuberculosis. And is any other test available? And beginning itself, I have said which, you should check for alternative specimen, good quality specimen, and repeat the test. And if it is still negative, you have to go for the additional test when indicated for bronchoscopy, CT chest, and assess for any additional comorbidities, and work up for persistent pneumonia. And if everything is negative, if everything is negative, then and ruling out all other diagnoses, you can treat the child as clinically diagnosed probable tuberculosis. This I have already said. Clinically diagnosed tuberculosis means the patient is highly suggestive with positive chest X-ray with often supportive circumstances like history of exposure to a TB or evidence of infection like a positive skin test for TB or a positive IgRA. And that is supportive circumstance, positive skin test for TB or positive IgRA, about which I will be telling in next. And rapid microbiological tests are negative. Common alternative diagnoses have been ruled out, and where facilities are exist, we have to send for a liquid culture for tuberculosis. And we have sent a repeat for our patient. We have sent a repeat sample and has found out that it is NAT positive, rifampicin sensitive, and he is started on first line drugs. And the next, don't forget to notify the patient and don't forget to test HIV for all patients diagnosed to have tuberculosis. And next 3-4 slides regarding skin test for tuberculosis, which everybody is having a lot of doubts whether to send or not. And just before it was included in the clinical diagnostic algorithm, but now this skin test for this Mando test is not included, but still it has the role. Now, the change is now, previously we used to call it tuberculin skin test. Now we have changed the name to skin test for TB. That is to include newer tests like CTB also. But it is not actually available, but still it has changed. And few words about Mando test. Everybody knows Mando test. The principle is when the patient is once exposed to tuberculosis infection, he will develop delayed hypersensitivity reaction. And when the patient we are subjecting to Mando, these T cells are already stimulated, and so they will secrete lymphokines, which will cause local induration at this site. Then the few practical points which you have to understand, remember, are the solution that we have T2TU purified protein derivative stabilized with RT23 is the standard one which we have to use. It is given intradermally, and in many labs use 5TU, 10TU and all, but positive Mando we are interpreting the horizontal induration of 10 millimeters or more, which is read at 48 to 72 hours. But when you are using this 10TU and 5TU, we cannot interpret it in the same way. Only if you are using 2TU, you can say as 10 millimeter positivity. And for HIV, it is 5 millimeter. And a patient, if we should, hello? Okay. We cannot distinguish infection from disease while doing Mando test. Hello. Disturbance.
You're audible. You're audible. Kekam, parnolu.
And only Mando test positive means just that the child is infected, and there is no guarantee that he is having a disease. So we can only use it as a supportive evidence for tuberculosis, not for diagnosis of tuberculosis. And Mando, when you are reporting, if it is negative, you should report at 0 millimeter or 1 millimeter, and not just say negative or positive. And the specificity and positive predictive value is also limited, because even BCG and non-tuberculous bacteria can also give a positive Mando test. And many a time you can get false negative results when there is a severe infection, HIV, malnourished, for recent infection with mumps, measles, chickenpox, and recent live vaccines, immunosuppressives, all can cause a false negative result, and false a wrong technique. When you are injecting Mando, that should be done in a 5 to 15 degree axis, and there should be a wheel of around 6 millimeter at this side. If that wheel is not there, then you should repeat that Mando in the other arm also. And for reading also it is important, because if the patient is coming, one point is if the patient is coming after 72 hours and within 7 days, a positive Mando is good, that is taken as positive Mando. If the child is negative when he comes between 3rd day and 7th day, then you have to repeat Mando in the other arm. And if the child is having a reaction, redness and all from the within 24 hours also, that is also not significant, because that is due to immediate hypersensitivity reaction. That is not due to delayed hypersensitivity reaction. And if the ulcers are developing also, and that does not mean that the child is having disease. And now the tuberculin source is getting lot is finished, and they so this is this point all of you should understand that it is an adjunct to other tests in diagnosis. And this new pyramid of TB diagnosis you can see, that I'll be telling next. And the most Mando test, the most important point is it is to detect latent TB infection, and that is done. It can be done as part of contact screening. For less than 5-year children, anyway, we are giving INS tuberculosis if there is no infection for a contact patient. But a child between 5 and 18 years also, you can identify latent TB infection and give INS prophylaxis if needed. That is given in according to the latest guidelines. So as part of that also, Mando is important. And for screening HIV infected children, and for giving children on immunosuppressive treatment like nephrotic syndrome or all, if there is a latent TB infection, you have to give prophylaxis with INS 10 mg per kg for 6 months. So here is the importance of doing a Mando test. And for academic purpose, CTB test is the new test. Even though it is not available, it is you should know about that. It is a point of care test which can be used in the field. And it is a specific test based on these specific antigens of TB like ES86. And so hence it is unaffected by BCG, HIV, atypical mycobacteria. So it is more specific. And the millimeter positivity is taken as 5 millimeters, done with the same Mando syringe, 0.1 ml. And IGR, one point about IGRA, what is interferon gamma release assay? It is similar, it is also an indirect evidence of tuberculosis infection. This is the third method by which we identify indirectly about tuberculosis infection. It is similar to Mando test, or it is done, it is a blood test, serological test that assesses latent TB infection by detecting interferon gamma generation by patients' T cells in response to Mycobacterium TB specific antigens. And you may have heard about quantiferon gold and T-spot test. These are the two IGRAs that are available. And these are the advantage is that only single visit of the patient is needed, and the result will be available in 24 hours. And it also, there is no cross-reactivity with the BCG and Mycobacteria avium. So it is more specific, but it just detects latent TB infection only, and it is costly also. And there is not enough data to support replacing Mando test by IGRA in low and middle income countries even now. And this is the new pyramid of TB diagnosis. Already Geetha madam has shown this. You can see that characteristic, this symptoms is down. Tuberculosis skin test is on this side, and center there is the radiology, and is the on the top is the microbiological confirmation with universal drug susceptibility testing in the upfront. So lower down it is sensitive, but higher up it is specific. This is the new latest pyramid of TB diagnosis. So to sum up, You have to know when a patient comes to you with symptoms of tuberculosis, identify presumptive pediatric tuberculosis, take a chest X-ray, it is in the upfront. Bacteriological diagnosis or confirmation should be sought anyway, and NTEP approach NAT is there for us for early diagnosis and detection of rifampicin resistance, and which itself is maximized when chest X-ray is suggested. And smear can be done if there is a delay in X-ray or NAT, and MGIT when possible if NAT is negative and high clinical suspicion. And skin test for TB should be a marker of infection. It can be used as an adjunct only and for detecting latent TB infection in special situations. Thank you.
Thank you, Dr. Rekha, for the very clear presentation. We have a few questions here. What is the minimum interval between the first and the repeat mantle?
There is on the next right other arm, there is no, it is not said about any minimum interval. When the child is coming after 7 days, you can do a repeat Mando test on the other arm.
Now, what about Manto positivity with lymphocytic leukocytosis, weight gain, and no recurrent infection in the past 4 months?
Pardon, question, can you tell the question once again? It's not clear.
About Manto positivity with lymphocytic leukocytosis, positive weight gain, and no recurrent infection in the past 4 months.
What is the relevance? It just indicates that child was exposed to Mycobacterium tuberculosis. Yes, but it is the child had got an infection. No evidence of disease.
Another question is how to diagnose latent TB. I think you spoke about it, but once more you can just
latent TB infection. You can that is. You can do a skin test for tuberculosis. Now our available option is Mando only. Cutaneous CTB test is not yet available, and IGRA also almost it is same for us, but it is costly. So no need for an quantiferon gold test. With Mando test, you can identify latent TB infection.
Another question was about IGRA, which you have answered. Then some of the questions Geetha madam has answered in the chat box, but I think Geetha madam, you can just elaborate that for the other viewers on YouTube. What is the difference between TrueNAT and CBNAT?
CBNAT is the one which is now there in all the district headquarters because government is providing it free. It is actually in the headquarters only. That means it requires electricity and the machine, but it is very easy to perform. That means the technician does not have much role. It is all done automatically. Whereas this TrueNAT is developed by some Bangalore-based company, and it is a point of care in the villages. That means it can be battery operated and you can take it to the villages. We all know these patients are there in the remote areas. So that ease of thing, because it has got an excellent sensitivity and specificity, TrueNAT. But the only thing is rifampicin resistance cannot be checked. So that is the thing. So that is actually being made popular now. And somebody has asked about BCG adenitis. BCG adenitis, because the only problem is usually some other infection like streptococcus or staphylococcus only. So you treat with antibiotics. Usually we give moxiclav and all for 10 to 14 days. And even if after that there is a huge swelling that the child cannot actually adduct the arm, we go for an excision. No need of any ATT.
Madam, another question is by Dr. Amit. A 5-day-old newborn who have received BCG at birth has significant contact with a smear positive grandfather. How to proceed? What investigation and if any, what is the dose of IPT, INH dose?
Usually INH same dose only. We give 10 milligram per kg, irrespective of whether BCG is being taken. But the most important one is to look for you look for any features of tuberculosis. Because if the grandfather is there, whether the mother had and mother we have not identified, so you check for the mother, and if there is no tuberculosis, well and good. And if the mother is already infected, then we'll have to check for others, like including an ultrasound we'll do. And then the most important one will be to carefully follow up the child.
Then a question has come for management of extrapulmonary TB and MDR TB. I think we are discussing that in the next week, isn't it?
Next week we are.
Okay, so we'll leave that question. Then choice of antibiotic and the duration of antibiotics that can be used.
So choice of antibiotics already mentioned. Don't give antibiotics having anti-tuberculous activity. Usually Ciplox and linezolid are the common ones which we misuse. The other thing you can ask in the respective cases, you can give the duration.
Then how long can we wait in BCG adenitis?
BCG adenitis. I think Priya, we are covering that in next session regarding.
Okay, yes, we'll leave that also. Then is 2-TU tuberculin available now?
Yes, it is the one that we are using. 2-TU that should be used. Nothing else other than 2-TU stabilized with 280 that should be used.
Then somebody has asked the topics in the second part. I think while concluding, Dr. Priya can just announce it so that they can get ready for the second part. That's all questions. Any more questions? You can raise hand and ask.
There is another question, one last question, Anju.
What is your experience with CB-NAT positivity? How many positive cases you have got in pediatric cases? Dr. Rekha? What is your experience with CB-NAT positivity? How many positive cases you have got in pediatric cases?
We usually get CB-NAT positive cases, but not that frequently. That is pediatric tuberculosis. Anyway, it is a all of you know that it is a paucibacillary disease. So there is difficulty in getting. Recently, we got actually a CB-NAT positivity for a skin tuberculosis patient. Skin tuberculosis child presented with a recurrent skin ulceration in inguinal area. For that child, also we got CB-NAT positivity. But
thank you, Dr. Rekha. I think if no more questions, our secretary, Dr. Priya, can wind up.
Anju,
yes, sir.
Can I add 2 points?
Yes, sir. Please, please.
One is about Dr. Geetha said TrueNAT rifampicin sensitivity. I think rifampicin sensitivity can be done with the TrueNAT. Confirm that is, okay, TrueNAT is a two-step process. First step is you detect the mycobacterium. If it is positive, then you can detect the rifampicin sensitivity. If it is negative, you don't have to do that.
Okay, so we'll just look up and just announce in the next meeting.
And the second is CB-NAT. Somebody has asked about the positivity. It is 1% in Kerala, if the overall CB-NAT sensitivity, whereas in national stats is 10%. And if the X-ray is suggestive, as 3 X-rays shown by Dr. Anju, then sensitivity will increase up to 40%.
Thank you, sir. Priya, over to you.
Thank you, Anju. First of all, let me thank Bala sir for accepting our invitation to release our newsletter. I also thank Narayanan sir for his presence. I thank the speakers for beautifully presenting the IAP NTEP module in a very concise form, because it is actually 350 slides and it is vast information. We know that the tuberculosis is a very vast topic, so it is very challenging actually. So I should really thank all 3 of them, our own Geetha madam, Anju Kanmani, and my colleague Rekha. Thank you very much. And I should actually thank Samir also, because Samir was there from the beginning. Our patient, Samir, was there from the beginning till the end. And I thank Anju for moderating the session very well. I thank Prashant and Amit for their dedication in bringing out our newsletter. And let me thank all the delegates, senior teachers, senior consultants, and for spending your valuable time, valuable evening with us with IAP Thiruvananthapuram. Thank you. And the next, we'll be back with the next module, with module 2 of IAP NTEP program next Tuesday. And hopefully we'll cover extrapulmonary tuberculosis, management of tuberculosis, and MDR TB. And with your permission, let me close this session, this week's Tuesday series.
One second, Priya.
പറഞ്ഞോളൂ സർ.
Okay, thank you all for coming for this Zoom meeting. Actually, about magazine, I think I should mention a little more, because if you from every month we are planning to release this magazine. Last page you should see. ഒരു അത്ര റെക്കഗ്നൈസ് അല്ല എന്ന വളരെ ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള വ്യക്തികളെ ഡോക്ടർ പ്രശാന്തും അമിതും കൂടെ കൊണ്ടുവന്നിട്ടുണ്ട്. ഡോക്ടർ MK ഭാനു വളരെ ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള വ്യക്തികളാണ്, എസ്പെഷ്യലി ഇൻ റിലേഷൻ വിത്ത് അവർ റോട്ടാവൈറൽ വാക്സിൻ ആൻഡ് വിത്ത് ORS ഇഷ്യൂസ്. കാരണം ORS വീക്ക് ഇപ്പോൾ വരാൻ പോവുകയാണ്. സോ ഇറ്റ് ഈസ് വെരി ഇമ്പോർട്ടൻറ്റ്, എസ്പെഷ്യലി ആൻഡ് വി ഹാവ് ടു thank you.
Okay, let me end the session. Okay, thank you.
Okay, please.